Well, welcome everyone. Let's get started. Today's our 6th webinar of the Maternal Equity Bundle. We're going to be talking a little bit more about bias and respectful care. So in these first 6 webinars, we are continuing to lean into what are our structure measures to support teams as we get the work done to address equity within our healthcare system. So we'll go to the next slide. So as usual, welcome. If everyone can keep themselves muted when we're not speaking, feel free to type questions into the chat during the duration of the webinar. We record every session because we will post these on our webpage, and so the archives of previous webinars are also posted on our webpage. We also have guests today, as usual, which we're excited to introduce, but first we'll start with reviewing the data. And then we'll go into a conversation on bias and respectful care. For those of you who are joining, or if you have not already, please put your name and your institution in the chat so that we can collect your information for roll. We go to the next slide. We wanted to put out that there is a new HRSA funding opportunity for teams. It's called the Integrated Maternal Health Services opportunity, where they're going to give 5 awards. The application closing date is at the end of May. So this allows teams to work on implementing maternal safety bundles and innovations for improving maternal outcomes, but it also allows us to identify lessons learned for future implementation. So a really exciting opportunity. If you have questions about that, you can reach out to us. You can also reach out to HRSA, refer to their website for that particular funding opportunity, and you'll have all of the instructions there on what's required or necessary to apply. We'll go to the next slide. And so we just mentioned the agenda already, but we'll go over the data that we have just briefly, and then we'll go into our conversation on bias and respectful care. We'll go to the next slide. So as always, want to thank our PEN-QUIN Maternal Equity Group. So this is our working group for this particular bundle that's helped shape the measures, the structure and process measures that we have. And also continue to provide feedback and assistance to us in terms of questions we might have or that you might have, particularly with regard to coaching. So if you need any help, just know that we're here at PEN-QUIN for supporting you with coaching calls, and we have a cadre of folks with a broad background, and that may be very helpful to you depending on what your particular need is within your organization. All right, we'll go to the next slide. All right, let's look at some data for a moment. And, I'm remiss if I don't mention at the top of this webinar, to Bonnie's earlier point, the data that's most catching of most folks' eyes these days in the news and in the media is that of the rising rate of maternal mortality that we've seen again this year. So the report and the data for 2021 has been released. So if anyone has not seen that, we can put a link in the chat to some of the most recent, the CDC link, and then also some of the more recent articles that have come out describing this rise in maternal death rates. We do know that this also related to COVID. We know the pandemic has worsened maternal mortality. There's more information to come from this data that's been released. So if you have not seen that, keep your eyes opened and your ears to the ground around more information that will explain some of the leading causes of those increased numbers of death. But we do realize and recognize that the pandemic would have worsened those numbers, whether that's due to COVID directly or a lack of access to care during the pandemic. All right, we'll go to the next slide. So as you guys know, when you submit data, it's due at by the 10th, of the month. We are submitting structure and process measures for all of the bundles that we have, and this being our 4th bundle. We still have open and available for those of you who want to submit their structure measures for opioid use disorder, for obstetric hemorrhage, and for severe hypertension. And then with our maternal equity, we're collecting both structure and process measures. Actually, am I saying that wrong, Kaylee? Are we still collecting process measures for all bundles?
Yes, that's correct.
Okay, let me correct myself. We are still collecting both structure and process measures for all bundles, as you see at the bottom of the screen. So for those of you who have just joined, if you could put your name and institution in the chat so that we can collect all information for roll call. For those of you who are participating, we have, we'll go to the next slide. I think the next slide is the picture of who's participating. No, it's not yet. I'll come back to that. So for those of you who are participating, we have approximately 20 some odd hospitals that are attending the webinars. and participating. So we have these 22 across the state. However, for those who are considered participants in our PIN-QUIN bundles, it's those who have registered and attend the webinars, have a memorandum of understanding with the Betsy Lehman Center, but also are submitting data. And so what's important here is that even though we have 22 hospitals that are moving forward with engaging what we've got for everyone for this equity bundle, the important part is to submit data. And we could work with everyone or anyone who needs support on how to submit data, on any challenges or obstacles that they have for submitting data so they could be considered a full participant. Pretty soon, we're going to move into supporting teams by providing participation reports to let each individual team know where they are and to be able to see their data given back to them. So if that's very helpful for you guys, we'll be actually putting out surveys as well to see, what's most impactful or what's most useful. And the previous surveys that we've done, we know what's very useful is for us to have these webinars and for everyone to collaborate and to bring their voices and share what's happening in their own institutions. In addition to that, if you're submitting data, we really think it helps you to drive the equity action forward for yourselves. We'll go to the next slide. So I wanted to just give a summary of how we've been doing with our structure measures. So we launched our bundle in September, and by October 10th, the data for everyone's September findings were due. And with that, we've seen some progress over time. So with actually there were 14 hospitals that have completed data submission, but 11 of those 14 are submitting regularly every month. So it's not that all 14 have submitted every month. So we've seen an increase from 42% to 71% having an equity team. It's really important to have within your department a team that's focused on and engaged in helping to create and put in place the structures and processes necessary to ensure that we're addressing equity within our maternal operations and maternal outcomes. We've also seen an increase in the diversity of roles on those equity teams. The diversity in terms of race, ethnicity, that's going to be really limited and dependent upon the race, ethnicity makeup of your organization. And so, that's related to HR and hiring practices. But so it's been pretty stable. We've shown that around a third, so I think that's 5, is that right? Hospitals have anti-racism statements. 1 has it posted. 3 I know have been working on it, and potentially 5 have completed them. So we have a number of hospitals working on an anti-racism statement to state their values and making those visible to the families that come to give birth in their hospital system, so that they're also aware that we are aware of inequities and that we're engaged in doing something about it. And then we've actually gone from 0 to 14% having goals or an aim statement related to their equity work. All right, let's go to the next slide. We'll also see that when it comes to collecting information, I want to sort of zoom everyone's eyes down into where it says ethnicity or race and ethnicity. And the third row where it says stratification, like our overall large goal and CDC's overall large goal is to support hospital teams across the US to be able to collect self-reported data on demographics that we know are important and find important, including race, ethnicity, and language, and then to stratify their outcomes or their clinical operations by that data. And we've seen an increase in stratification. So it's safe to say that we're moving towards our goal, and we're really excited about that. All right, we'll go to the next slide. And so here you can see visually that we've gone from the 46 to 71% of teams that are engaged in this bundle, increasing their presence of having a formal equity team. And we'll go to the next slide, and we'll talk a little bit about one more structure measure before we turn it over to our guests. And that is our PREM, the patient reported experience measures. Across the time, you can see that blue bar where it's fully in place. We've gone from 3 hospitals to 8 hospitals who are reporting that they have implemented a PREMs in their hospital system. That's also extremely important in the sense that what we know when it comes to inequities is that there are people who are giving birthing individuals, whether it's differences by language, race, location, and geography, rural or not, who feel like their care is not adequate. And so having these patient report experience measures in place allows us to know how we're doing from the patient perspective. And so it's really nice to see that 8 of the 11 regularly reporting hospitals have implemented a PREMS. And so we're moving toward goal in that target as well. So we'll go to the next slide and get ready to have a presentation from our guest speakers. What we'll share here is just coming soon. We already mentioned that we're working on distributing regular reports of your AIM data back to the submitter so that it's not just your SMM report, but a report of your participation and how things are going. Opportunities can be given retroactively to submit your data and edit submissions that are incomplete, so we can work with teams on that. And these reports will be part of a new structure measure to more clearly define and recognize your participation with AIM bundles and with our PQC specifically, because we know there's a lot of movement happening with CMS on how engaged hospital teams are to be birthing friendly hospitals. All right, we'll go to the next slide. And I'd like to turn it over to our colleagues and friends at the New York State Department of Public Health, as they'll talk about their Birth Equity Improvement Project. So we have Kristen Lawless, who's the program director for the NYS PQC and is within the New York State Department of Health, and also Jackie Kellachan, who is also a project director for the Birth Equity Improvement Project. So they will come and speak to us, or thank you for joining us. And they've come to speak to us about how they've implemented and moved bias and respectful care forward through the state of New York. So I think you guys are going to really like what you're going to hear. I'll turn the microphone over to you guys.
Thanks so much, Dr. Meadows, and to your PQC team. We're really excited to be here and share with you. We're definitely open to any questions. So if at any point you want to raise your hand or chat in the chat box, we'll definitely get to that. And we're going to be talking to you today about the New York State Birth Equity Improvement Project, or the NYSBEP is our acronym. And this is a part of the New York State Perinatal Quality Collaborative. Next slide, please. So at the end of this presentation, we hope that you'll be able to understand how disparities in New York State's perinatal outcomes and the experience of Black birthing people led to the development of the New York State Birth Equity Improvement Project, review data from a 2021 baseline assessment of New York State birthing facilities' current practices and procedures to provide equitable care for all birthing people, understand how New York State birthing facilities began doing equity work, and finally, understand how New York State facilities are starting to collect and use patient experience data to improve the quality of birthing care in their facilities. Next slide, please. So we'll begin with a maternal mortality overview of how things look in New York State. Next slide. So over the past 20 years, maternal mortality has increased, and looking at the US rate, you can see that it has significantly increased since 2001, doubling from 10.3 to almost 19.7 in 2019. While New York State often performs well on public health measures when compared to the US as a whole, maternal mortality is a measure where the New York State rate mimics the US with a slight increase of its own from 18 per 100,000 to 19.3 per 100,000 in the same time period. Next slide, please. We also want to talk about the racial disparities that we're seeing in maternal mortality. In New York State, the ratio of Black women and birthing people dying during pregnancy or within 6 weeks of giving birth is 3.3 times that of their white counterparts. Nationally, Black women are 2.5 times more likely to die than their white counterparts. So this tells us that while racial disparities persist across the United States, New York State actually fares worse when it comes to racial disparities in maternal mortality. Because of this, you'll notice much of New York State's work on maternal mortality culminating in this project emphasizes reducing racial and ethnic disparities in outcomes. Next slide. So this is a quote from Dr. Donna Iene Davis. She's the director of Women and Gender Studies at CUNY Graduate Center in New York City, and she was an advisor on our expert panel for this project. And she said, understanding the Black birthing people's experience, how they understand racism, not how we understand racism. Next slide. So in 2018, the Department of Health hosted Voice Your Vision listening sessions with birthing communities statewide. Participants talked about many issues. Some of them were unique to where they lived, and we did see some differences between upstate New York and downstate, more towards the city. However, what was by far the most striking result was the consistency of most of the feedback we received across the state. Regardless of geographic location, people from large communities or smaller ones, many of the experiences shared were incredibly similar. So much so that analysis of the feedback we received identified 6 major themes that recurred in all listening sessions. And these themes included feedback on health systems, providers, racism, education, disrespect, and social supports. So as far as health systems, descriptions of or a belief in variable quality of care depending on the facility and insurance type. So people felt they received worse treatment when they were on public insurance. As far as providers, we heard about a lack of connection with many healthcare providers, a desire for more time with their providers, better communication was needed, and also an interest in building more trust. As far as racism, we heard clear, explicit, and consistent feedback about the lived experience of racism in the United States and specifically in New York. Related to education, there was a desire for more formal and informal education around pregnancy and childbirth, including classes with peers, education in their home area or neighborhood, and better online tools and resources. Related to disrespect, there were pervasive feelings of being disrespected when coming into contact with the healthcare system and providers, from reception and admin staff to providers and to social services and support staff. And finally, in relation to social supports, they expressed a lack of community and social support, feeling a need to build a village, and they wanted more opportunities to engage families in their care. So if we can move to slide 8, we're going to go through and provide some of the quotes that we heard from people during the listening session. So related to racism, they look at your skin color and your pocket and judge you based on that. We're high risk because we're Black. Oh, sorry, can we go back one? Thank you. Receptionists puts a single on the form. There's an automatic assumption that because you're single, because you're Black, you're single. Black doctors understand us because they are us. Related to unequal treatment, we heard after having the baby, the nurse came in at 3 a.m. asking what family planning method I wanted to use. Just because I'm Black or Latina, they want to make sure that we stop having babies. They always want to induce Black women. And a feeling that you gave your rights away when you walked in. Related to bias, they are pulling to get respect. Doctors don't respect us because they don't value us. I feel like they brushed off my concerns. And women of color are tired of feeling like we have to fight for this right that should just be given to us. Next slide. Related to bias within the systems, we have a couple categories here. So starting with health systems, we heard they're trying to push for you to do other things that cost more money. They push the drugs on us like an experiment. You are already labeled and you are already treated a certain way. Related to providers, we heard that individually, we all have our own stories. Not all pregnancies are unplanned or don't have a father around, as well as you have to show them you are somewhat educated, the need to prove themselves. Related to information and education, you have to make a plan yourself because they don't tell you what the plan is. A feeling like you're just on your own, continually fighting to prove that you can understand. And related to social supports, we used to have a village and today it's gone. Moms need support and that's the bottom line. Men need support services too. They also are going through something. Next slide. So one of the first things we did when we started this effort after having the listening sessions was to develop a facility readiness assessment, or what we call the FRA for short, to see if facilities were ready for this. What was the state of things in each facility regarding equity? So kind of like a gap analysis to see what areas that we really needed to focus on. Next slide. So the Facility Readiness Assessment Survey assesses the facility's current practices and procedures to provide equitable care for all birthing people. And it went in, all the questions fell into 4 different buckets: organizational commitment to equity, staff equity, training and evaluation, leadership and staff composition, and then patient data, voice, and influence. So we can go to the next slide. So the survey was distributed in a link via email SurveyMonkey to all birthing facilities in New York State in December of 2020. All facilities were asked to complete the survey regardless of whether or not they plan to participate in the Birth Equity Improvement Project. The analysis was performed with surveys received by June 2021, and 72% or 89 of our 123 New York State birthing facilities responded to the assessment. Next slide. So some of our key findings were that over half of the facilities had a documented public commitment to equity. So that seemed great. But then when we got a little bit more in depth of things, only 15% had a written equity plan with a process to monitor the progress. Most facilities had implicit bias training, anti-racism, or cultural competency training available to their staff. About half of the facilities reported that staff composition reflected the patient demographics in their community, but only 25% reported that they analyzed staff race, ethnicity, language, and gender to serve diverse patients. Almost all of the facilities responded that they collected patients' preferred language, race, and ethnicity, but less than half reported using that data to address healthcare disparities. Next slide. So now we're going to move into the implementation of the actual New York State Birth Equity Improvement Project, which, as we mentioned, is part of our Perinatal Quality Collaborative and follows that structure that we've done with our birthing facilities for about the past 10 years now. So if we can go to the next slide. So our project goal is that all New York State birthing hospitals and centers will identify how individual and systemic racism impacts birth outcomes at their facilities, and they will then take actions to improve both the experience of care and perinatal outcomes of Black birthing people in the communities they serve. The project launched in January of 2021, and at this point, we have 73 New York State birthing facilities participating, and that does include both hospitals and birthing centers. Next slide. So the equity curriculum in this collaborative tries to create awareness of racism at the individual level, but it also wrestles with how participating teams can take the first step or the next step to create a change in the facility's practice of care for birthing people. So some of the things that we have focused on to date are up on the screen. We have talked about the experience of Black birthing people. We've had people come on and share their lived experience, as well as husbands and family members come on who have actually lost someone to maternal mortality, the impact of racism on perinatal health, the equity systems continuum, the importance of intentional listening versus non-intentional hearing, the cultural humility shift. We talked about implicit bias and then transitioning into anti-racism, individual bias versus systemic bias at the facility level, staff's experience with racism, authentic patient engagement, shared decision-making, and engaging fathers and partners. So on the next slide, you'll see our structure measures. And our structure measures are collected quarterly, and they're used to track progress among the uptake of certain policies and procedures intended to improve birthing people's birthing experience, specifically Black birthing people. So you can see here, our structure measures are focused on policies and procedures that are in place to address equitable care, written action plan to achieve equity benchmarks, including shared decision-making, anti-racism education in place for staff, which may include equity, implicit bias, diversity, and inclusion training, updated job descriptions and evaluations for labor and birthing staff that include racial, ethnic, and linguistic justice. The patient-reported experience measure, or the PREM survey, is implemented and offered to every person with a live birth at discharge. And finally, collection and review of perinatal and demographic data stratified by race, ethnicity, language, and gender. So if we can go to the next slide, at this point, I'm going to turn things over to the project director, Jackie Kellachan, to go over how we began this work.
Hi, everybody, and thanks so much, Kristen. Thank you for advancing this slide. So many of you have already began this work at your hospitals, but I think that it is really challenging to start talking about this work, start forming your team. Just like in your project, you know, we asked our teams in New York State to have a team that had racial and ethnic diversity, but also had diversity in terms of the different staff focuses, clinicians, social workers, etc. But in starting to try and advance equity, what you need to do is first start talking with your team. And so if you could go to the next slide, what I thought I would do is share a PDSA that was done by one of the hospitals in our project that speaks to how they got started with this work. Next slide. So the goal of this PDSA was to find out if implicit bias existed in the mostly white workforce in this hospital. And a short PDSA was conducted, and the goal was to have hospital staff of all types give their predicted level of bias and their results from the Harvard IAT race tests. And so they targeted nursing staff, secretaries, med techs, leadership, a variety of providers targeted to participate. And the goal, just for this very first PDSA, was to have 25% participation, and they were able to get actually 38% participation. And so what they kind of found out, as you'll see, is that there was a culture of disbelief coupled with a high degree of willingness to engage. So next slide. Thank you. And so the plan for this PDSA was to assess the consciousness of implicit bias among staff at the hospital. And they presented the test while people were working on the floor, and people were asked personally to participate. The PDSA lasted 1 week. And on the bulletin board in the staff lounge, they put kind of a one-pager up, you know, asking people to participate. And there was also a page that, you know, had the link to the test, and it also asked people to predict how they thought they would do on the test. And as mentioned, there were 23 responses. Next slide. And so each participant was asked to predict their level of internal bias towards European Americans versus African Americans. And most of the workforce there, 86%, predicted that they would have little to no or only a slight bias for European Americans versus African American people. Next slide. And so actually what the results showed, very different from what was predicted, but the staff at Northern Dutchess Hospital were very much in line with the national average from the Harvard IAT test. So it showed a strong automatic preference for European Americans compared to African Americans. Next slide, please. And so this was, you know, per Northern Dutchess Hospital, people were like really surprised because they really thought they had no bias, that this was not us, that this was not our facility. Some people said, you know, how could this test doesn't work. Some expressed shame, how could this be? Others shared, you know, embarrassment, like, you know, please keep this confidential. But one of the things that Northern Dutchess found gradually, that there really was an openness to listen, and people kind of going from the spectrum of denial to saying like, you know, wow, I never knew, you know, that I had this kind of implicit bias, that this kind of bias. Next slide, please. And so then the Northern Dutchess team took a deep breath, you know, they talked through it, and they went from a culture of disbelief to one that said, okay, so, you know, what can we do to start change? What can we do to start the work on this project to help us change and to help the patients that we're serving? Next slide. And so what they decided with this small PDSA was to try and do it, roll out a bigger one at their hospital, but they also used it as an opportunity to get volunteers to be part of their work, to be part of their project team for their own, you know, birth equity improvement project. So this is just an example of how one team started the work in their facility. Next slide, please. So, so now I'm going to jump to a different topic. You know, just like your teams, we've asked our teams in the project, they have individual project goals. They're collecting data on the structure measures. But one of the things that we started doing in this project is that we started collecting and we started using experience data from birthing people at all the facilities in the project. Next slide. So we, our team developed a patient-reported experience measure. We call it a PREM for short. And this is our outcome that is centered on birthing experience. And it's an anonymous 17-question survey for every person discharged with a live birth during the project period. And birthing people use a facility-specific QR code to access the survey, and the data comes directly to us for analysis. And on a monthly basis, we feed the data back to birthing facilities through what we call a PREM facility report and also a trends analysis report. Next slide, please. And so each of the each facility gets its own PREM implementation packet, and in the packet are what we refer to as scan sheets. This is an example of it here. And as mentioned, each team has its own facility-specific QR code, and this discharge sheet and the survey are available in 12 languages, including English. Next slide, please. And so in the implementation of the PREM, what we've asked facilities to do is to post the scan sheets in rooms, to put them in discharge folders. Best practices have shown that we have the most successful implementation at a facility when staff, or even better, volunteers, help birthing people access the surveys via a facility provided tablet at the time of discharge, but the survey can also be accessed via the birthing person's smartphone. The survey takes less than 5 minutes to complete. And here's just an example of some of the questions that are asked on the PREM survey. Next slide, please. So the PREM survey was launched mid-July 2021, and this shows data through December 2022. The PREM is ongoing, but through December 2022, we had about 26,000 PREM surveys completed. And the black line shows the surveys that are included in analysis, and surveys included in analysis if it has answers to at least 2 of the 17 core PREM questions. Some surveys are excluded from analysis just because not enough questions are completed. Next slide, please. So now what I'm going to show you here is some data on one of the questions in the survey. So question number 6 on the survey asks birthing people to respond to the following statement. I felt pressured by the healthcare team into accepting care I did not want or did not understand. And for birthing people who strongly agree, or are neutral to this statement, in other words, they have a negative response, they are feeling pressured, we group those together. We're really interested in looking at the kind of undesired responses to our survey questions, because that's what we want to work on as a project, and that's what we would like our teams to focus on. And so, as I mentioned, this is really across the board the lowest scoring question in our project. And as you can see, about 20% of all the birthing people who have completed the survey in this project strongly agree, or are neutral to this statement. And you can also see that we really have not had any improvement. It's practically a straight line. And this is an aggregate response. So if you go to the next slide, you can now see this response stratified by race and ethnicity. And so if you look at the response by white birthing people, you see that it's a little bit, above or around 10%. And this is in contrast to the response by Black birthing people, which is around or just under 20%, Hispanic birthing people, which is above 20%, and Asian birthing people, which are closer to 30%. When we give data back to the facilities on a monthly basis, they do see their own facility data trended in this way for every question, and they see it stratified by race and ethnicity so that they can see what's going on in their facility. And then they can also compare their results to the project average. And so then, next slide, please. And so then what we've been exploring in our coaching calls is trying to see and share what best team practices there are that could help relieve pressure on birthing people. And so next slide, please. So now I'm going to just share what some of those ideas are from some of our teams. And so this next one, it comes from Upstate Hospital, which is in Syracuse, New York. And so what you can see here is they've taken their own facility data for question 6, and that's actually the solid line that goes up and down. And you can see that they've tracked different interventions that they've tried to see how that would impact patient experience. And this is not stratified. This is their aggregate response data. So you can see that they, had tried a video with their staff on top 10 labor positions. They had a campaign to ask permission PDSA with their birthing people. They had a shared decision-making PDSA. They also employed different labor comfort techniques. And then they also did a spinning babies PDSA with their staff. And so they're trying to understand what is working or not. And so that's what Upstate is doing. Next slide, please. So a different example comes to you from Maimonides Medical Center, and they're in Brooklyn, New York. Next slide, please. And so what they've been doing is that they've been doing what they call patient experience rounding, and that's daily rounding every day around patient's experience. And they ask them about everything that they're going through. And depending on the feedback, they try and have real-time service recovery or escalation to the respective department, again, depending on what the feedback is. So really trying to address complaints, poor experience in real time. Next slide, please. This next example comes from New York Hospital Queens, which is part of New York City's public hospital system. And so what they've done as an additional way of incorporating lived experience into their project is they're participating in a pilot doula program along with a couple other hospitals. Elmhurst Hospital is a public hospital. Mount Sinai is a private hospital. Caribbean Women's Health Association is a community-based organization. The New York City Department of Health and a doula service. And they have monthly advisory board meetings where they invite patients and other community members to share their experiences on birthing care in these facilities. And then they bring that back to their team at their hospital at New York Hospital Queens. So that's an example from New York Queens. Next slide, please. So this comes from NYU Brooklyn. Next slide. So one of the things that they're doing is that after every discharge, a birthing person receives a post-discharge phone call. Okay, and they actually have the opportunity on their own time when they're at home to share their experience at the birthing facility. And then the patient's comments, whether they're positive or negative, are noted, and then they're shared at a weekly patient experience meeting with all team members. And then the team works on those ideas. And then this next one comes from NYU Manhattan. And next slide, please. And so at NYU, they have established a Black Mothers Matter committee, and they've created their own navigator program that's specifically focused on providing culturally congruent care to support Black childbearing families. And what they do through this navigator program is they provide care coordination, they provide monthly safe spaces and support groups, they provide intrapartum support, and they also have 1 year of postpartum follow-up. And this is something that was piloted at NYU Langone, and then they're making this system-wide across their 2 other facilities in New York, NYU Brooklyn, and also NYU Long Island. Next slide, please. So one of the things that we talk about in our project a lot, because we have a lot of different facilities that have a lot of different kinds of patient populations, is that it's really important to consider the impact of your facility system on even one Black birthing person. Black birthing people are the experts on the accountability, the empathy, and the humanity of your system. Next slide, please. And so that's what we had to share with you today. And both Kristen and I are happy to, take any questions or go back and talk about, any of the slides that we discussed if you want to hear more details.
Thank you. That was terrific. I'm looking in the chat to see if there are any questions. Can have anyone raise their hands if we have any questions. I'm just looking for raised hands and comments and questions in the chat. There's a comment. This is wonderful. Can you talk about funding that you've used to support capacity building around this? And then Kelly also asked if we could go backwards and show the last slide.
Is that the slide you were looking for, Kelly?
Yes, thank you.
Okay, great. And please feel free to chat in any questions. And regarding funding, so we have received funding from the Centers for Disease Control and Prevention for our PQC for the last cycle of funding that we received, the last 5-year cycle of funding that did include the New York State Birth Equity Improvement Project. Additionally, we were able to identify some state funds and through our Maternal Child Health Services block grant, and we used those to contract with NICHQ out of Boston to help build some of our capacity around this. But I do have to say, we do a lot of work on a very limited budget.
Mm-hmm.
Let's see.
And for the next question in the chat for the PREM survey, if we're able to go back a few slides, I can share the questions. I can't remember what slide number that was on. Maybe if you go back about 10 slides, we can share some of the questions. So this PREM survey is actually a specific survey. It is not the Press-Ganey survey. We looked at some surveys on respectful care that existed, and we really wanted to ask specific questions about birthing experience and care. And in addition, we wanted to ask specific questions about treatment, and specifically if people felt they were being treated differently because of their race or skin color, because of their ethnicity, because of their sexual orientation or gender identity, or the type of insurance they had, etc. So I hope that answers that question. I think that there was, for this survey, we just wanted to include people with live births. We felt that was appropriate for this survey. So that's just what we decided at the beginning.
There's also a question about the PREM survey. I know you're showing it.
So
no.
This is for New York State, and certainly we have been, even though our project started in 2021, we have had different teams join at different times. And once they have kind of satisfied all the things that we need them to satisfy to join the project, then we train them in implementing the PREM, and then they can start the PREM.
Can you comment at all? There's often been some discussion where we've talked about what is a PREM. And is there a difference between patient experience and patient satisfaction? And so a patient experience measure is not a patient satisfaction survey, really is more around how they describe their experience in terms of respect and autonomy are 2 areas that we're really interested in. So I think there are some comments in the chat to talk about the kinds of surveys others are using as a PREM. We've presented and shown that the birth lab with Dr. Sarah Vedum shows her Madam and Maury, which we consider a PREM because they really get at patient experience on respect and autonomy, more so than did I enjoy my care? Was I satisfied with my care? And others in our groups have said, well, we have a Press-Ganey survey, or we use HCAHPS with specific questions, and just wanted to hear your comments on how you've engaged or talked to your hospitals who also may have HCAHPS or Press-Ganey and get some information from patients on whether or not you factor that in, or why it was that you went toward PREM over those surveys.
So we did use the UBC survey as a guide, and we felt like we wanted to add additional questions about mistreatment, even though they do have a mistreatment survey. So we wanted to kind of combine them. I think that the work in birthing experience and respectful care around birthing is evolving, and there's a lot of new work and ongoing work being done. So I feel like ours, this is not definitive by any means. We have not talked about Press-Ganey or other patient surveys, comparing them or using them. In the project, we have been, not every hospital participating in the project has implemented the PREM. There are other ways of getting, patient experience or patient satisfaction. And I think that, we're not excluding those facilities from participating. What we're saying is, use those, right? Use those to try and, create more respectful care. But for the work that we're doing, we are focusing on using the measure that we developed. And I have to say that, we presented the data today just in the slides that I talked through on question 6, but we're also, really trying to make it more useful, and we're exploring, a different way of expressing the data to make it more understandable and make it more useful to the team. So we're really trying to evolve this as we go. And I think as the knowledge, on these measures evolves.
That's really helpful. There's also just a comment that Kaylee made. So what we'd invited our teams to participate with Team Birth to have a shared decision-making tool on their labor units, and to also engage their teams, shifting toward that culture of teaming and culture of equity. And with that, PREM is used for measurement. And so with Pinquin, we developed our own PREM in partnership with Team Birth. And that's what our groups will be using, and just wanted to let our teams know it was based off of the work that Jackie and Kristen had done already in New York, as well as in collaboration with work that you'd heard from Illinois in a prior webinar. So that's how our PREM has also become developed. So we have it available for any hospital to use, even if they're not working with Team Birth. I also see that Dr. Belanoff's hand is raised. And
Hi. Thank you. This is so cool. I just love these data so much. And you're also, I'm from New York. I had a baby at Maimonides Hospital. I was born at Mount Sinai. So you're bringing back all the memories. And I will say I had a pretty choppy experience at Maimonides back in 2001 when my child was born. But anyway, one of my questions is, and one of the things just from my own experience that this brings up is, I'm wondering, were you interested in parsing the differences, the different experiences people had between, with their doctor, with a nurse or midwife or other care providers during, say, labor? I remember just, again, had a great doctor who I loved so much. And, but then another doctor who was working with her was like kind of a nightmare. And then the anesthesiologist was kind of a weirdo. And a nurse woke me up at 5 a.m. telling me to brush my teeth. So, all these things that vary across the providers. I wonder if that's of interest. And then my other question, because I just have so many, because again, this is so rich. I wonder whether you have the data or capacity to correlate, the levels of disrespect or adverse experiences that people experienced by race. And I'd be interested to know whether, whether white people's report of disrespect or whatever was correlated with folks of color, because I think, in part, I think we need to demonstrate that, disrespect, which is, almost always going to be experienced worse for marginalized groups, is also experienced by dominant groups, and that they should be invested in this as well. I'm not sure if I'm saying that very sort of eloquently, but that, that the sort of culture of, lack of agency or disrespect pervades everything, and that we should all be invested in dismantling it, with particular focus on folks who are most likely to be the subject of it. So anyway, I know there's 2 questions there, I'm cheating, but whichever one you feel like answering, I'd be happy with.
Okay, so for the first one, we did really struggle when we were developing the questionnaire with presenting questions by type of provider, and that became too lengthy. And so we grouped provider together, and instead we have a question that asks about treatment at different stages, at admission, during the birthing process, at postpartum, etc. So you raise an excellent point, but for this survey, we found that that was too complex for us to tackle. So the second question, so we do present all of our data back to the teams, stratified by race and ethnicity according to the groupings that was showed on the slide before. So we show that for Black birthing people, and that includes Hispanic and non-Hispanic Black birthing people, white non-Hispanic birthing people, Hispanic birthing people, Asian birthing people, and then we have two categories of two other categories. One is mixed race, and the other one is didn't, race not responded to. Either they skipped it, or they actually intentionally chose not to report their race. So we are providing that data back. And I think that, again, depending on the facility, you can see the good or poor experience that anyone in any racial or ethnic group is having. One of the things that as a team that we have been really talking about lately is, we really want to, our priority for this project is to improve the experience of Black birthing people. And so we really want to highlight that experience. And if you have a high percentage of Black birthing people not having a good experience of your facility, whether the denominator of that is 1 or the denominator of that is, 200, that is what, we hope to have the facilities work on, right? Regardless of the percentage of other population for race and ethnicities. And I think that in talking about this with our team, we come back to this a lot, because I think that in public health, we have a kind of in some ways a binary that asks us to compare, a Black birthing experience against a white experience being like, this is how it should be. This Black birthing experience does not mean anything to me unless I see it compared to white birthing experience. I think it's very important to look at Black birthing experience on its own, and if it is not good, if someone's having a poor experience, isn't that enough? We should really work at improving that Black birthing experience. I don't know if that answers your question. I got a little rambling.
Yeah, and I could not agree more with that.
Yeah.
I mean, I really just, and I definitely want to be clear that I'm definitely not saying, hey, don't forget about the white people.
No, but this is, we actively, I think it's something that's very important to discuss,
Yeah,
and
no, I
Yeah.
agree that making white the baseline is also a big mistake. I'm thinking, improving things for folks who are most likely to have an adverse experience for Black birthing people will probably improve things for everyone too, and that we need to just make sure that people understand that this isn't, anyway, but thank you so much for both of those answers. It's really helpful.
Yeah, you're welcome. And Kristen, do you want to add anything?
I thought that was great, Jackie, and really eloquently put. And I just want to add that this has been an ongoing discussion for us, because we've actually had some hospitals say, when we were first looking at it, we were looking at the answers of Black birthing people around the answers of all all people that responded. And we had some people say, can we see it against the white people's responses? And we've had ongoing discussions about this. And I think, you know, what Jackie just said, correlating it against white people isn't necessarily the standard. This has been a learning process for all of us. This whole project has been, but I think Jackie really hit it all on the head.
I see that there's a question, how do hospitals correlate the PREM questions with evidence-based solutions? That's a really excellent question, because I mean, and I'm just gonna ask a question, you know, because I'm new at this work too, you know, what are evidence-based solutions to inequity? You know, what are the evidence-based solutions in the hospital space to relieve pressure, to increase autonomy, right? These are things that I feel like, you know, in our project that we're, you know, trying to figure out, like, just like, for instance, team birth, which we have, you know, we've seen team birth presentation also, and you know, that is an interesting, you know, solution and technique also. So, you know, we're seeing what hospitals are doing, and we're sharing them, because you know, I mean, I would love to open it up and hear from this group about what are the evidence-based solutions to you know, improving equity and using experience data, you know, to improve equity. You know, it's a work in progress, I think. And, you know, I'm really interested in all the work that's being done across the country, you know, in this, because I feel like maybe in a few years, there will be evidence-based solutions.
Lots of congrats and thanks in the chat. And thank you for attending to Cami Berardi, who's made a comment. Thank you so much for allowing our team to share the progress today. Thank you, Cami. Also, Cami's a Massachusetts resident and a board member and supporter of PinQuin Project. So thank you, guys. Do we want to show final slides? Any final slides, Kaylee, for? You know, we have 1 minute left. We just wanted to show maybe a slide on our upcoming summit, which is on Wednesday, April 12th. And our next monthly webinar will be April 18th, same time, same place. And here's our summit on April 12th from 8 to 4:30. So if you have not already registered, here's a QR code for registration. We'll also have a panel during the summit on Aftershock. We'll have a special viewing of Aftershock, which is a movie that showcases the lives of two families, actually in New York, that then were, unfortunately, their families experience a maternal death, and how these fathers beautifully move through their lives to gain support and to think about how to address the U.S. maternal health crisis. And go to any other next slides, and I'll let you take over from here, Kaylee.
Sure, just a few other announcements about upcoming events. March of Dimes is having an event on April 20th at 4 p.m. A panel discussion on the impact of lead in pregnancy and infancy. This event is on our website, and we'll also share the details in our follow-up email to this webinar. The AIM National Program also regularly has webinars similar to this one, where they just cover various technical assistance topics. A couple coming up in the next few months are related to new resources for American Indian and Alaska Native communities around urgent maternal warning signs. And then also in May, a webinar on care for pregnant and postpartum people with substance use disorder. That bundle was our very first in Massachusetts, so anyone who is still continuing that important work might find this webinar helpful. And then lastly, just want to continue to spread the word about Speak Up champions and ambassadors, implicit and explicit racial bias education. We have almost 500 perinatal providers who have taken champions training between about 2020 and now. And the next training is coming up on May 3rd and 10th. And then for those of you who have already taken champions training, there are 2 opportunities this spring to become Speak Up ambassadors and just expand your knowledge and capability to help address implicit and explicit bias in your hospital system. And I think that's it for today. Thank you all for the extra minute.
Thanks, everybody. And thank you again to Kristen and Jackie for a fantastic presentation. I think we learned so much, and just a huge body of work, and such dedication from the state of New York to really move this needle forward. And we're all following your lead. So thank you so much.
Thanks for having us. Thanks, everyone.